Okay, so welcome to this video. In this video what we're going to discuss is amyotrophic lateral sclerosis, okay, or ALS for short. Right, so let me outline the structure then for this video. What we're going to do is we're going to start off with a discussion of why amyotrophic lateral sclerosis is an appropriate name for this disease, okay, so what the name actually means. We're then going to talk about the fact that there are many different names for this disease, so I'll talk about the different names that you might hear this disease called. Okay, then what we'll move on to is a discussion of the symptoms of the disease and how it progresses and how usually it's fatal and how it ends up killing you. Okay, and then what we're going to do is we're going to talk about which neurons die in amyotrophic lateral sclerosis, because it fundamentally is a neurodegenerative disease, okay, which means that it's going to kill neurons, and certain neurons are going to be affected in amyotrophic lateral sclerosis, and this is how it's going to cause its symptoms, basically. Okay, so we want to see which neurons are going to die in amyotrophic lateral sclerosis, and then what we'll do right at the end is look at the actual process of neurodegeneration, what actually causes the neurons to die in the first place. Now, the reason we're going to do which neurons die before we actually talk about how the neurons die is that actually amyotrophic lateral sclerosis does not have one answer as to how the neurons actually die. In many different people, it seems that the actual reason that these neurons die is different, basically. So, in a sense, there are loads of different types of amyotrophic lateral sclerosis, but at present, at our current understanding of this disease, we categorize them all as one, okay? So, all the characteristic feature then of amyotrophic lateral sclerosis is which neurons die, and therefore why you get the certain symptoms that you do. Okay, it is not a core pathological process, i.e. the neurodegeneration that actually causes those neurons to die is different in many different cases of amyotrophic lateral sclerosis, so it is not a specific type of neurodegeneration, basically. That's what I'm trying to say, that there are many different ways that the neurons can die. What characterizes this disease is not how the neurons die, but which neurons die, and therefore, despite the fact that there are these many different ways that those neurons can die, they all present with the same symptoms and therefore are all grouped as amyotrophic lateral sclerosis. Okay, right, so we will leave the actual neurodegenerative process right until the end, therefore, because the actual characterizing feature of amyotrophic lateral sclerosis, as I've just explained, is not the neurodegenerative process, it's which neurons die, okay, and how that then causes these symptoms of amyotrophic lateral sclerosis. Okay, right, so first off, the disease affects around 1 in 50,000 people, okay, so it's not horrendously common, but it's not horrendously rare either, okay, and I now want to discuss why it is called amyotrophic lateral sclerosis. Okay, so let's tackle this first word first. So we're going to tackle amyotrophy. Okay, what does amyotrophy mean? Okay, amyotrophy means neurogenic muscular atrophy. Okay, so what does atrophy mean? Atrophy is a fancy word to mean wasting away. So muscular atrophy means that the muscles are wasting away. Okay, so this word atrophy, this means wasting away. Okay, so in amyotrophy, you get wasting away of the muscles, okay, and then the word neurogenic, what does that mean? Well, this means that the reason the muscles are wasting away is something to do with problems on the level of the nerves that innervate them, okay? So the reason the muscles are going to atrophy in amyotrophic lateral sclerosis is because they no longer have motor neurons innervating them. The motor neurons that innervate them are going to degenerate, okay? And if you don't have motor neurons innervating you anymore, then you're no longer getting any sort of trigger to ever contract, and therefore gradually you waste away, okay, because you're no longer needed, you're not being used at all, because the neuron is no longer there. Okay, right. So that's what amyotrophy means. It means wasting away of muscles, okay, because of problems on the level of the motor neurons which innervate them, so neurogenic muscular atrophy. Okay, then the other portion of the name, the lateral sclerosis. Okay, what does that refer to? Well, this is something that unfortunately can only be seen by a pathologist at autopsy. Okay, this refers to a feature of the spinal cord. Okay, so when pathologists examine the spinal cord of people who have suffered from amyotrophic lateral sclerosis at autopsy, what they find is that the lateral portion of the spinal cord is extremely hard, basically. Sclerosis means hardening. Okay, so basically, the lateral sclerosis refers to the fact that the lateral portion of the spinal cord has hardened, and we will look into why the lateral portion of the spinal cord hardens later on, okay? But that's the origin of this name, amyotrophic lateral sclerosis. You get amyotrophy, and you also get lateral sclerosis of the spinal cord. Okay, and for short, amyotrophic lateral sclerosis is usually abbreviated down to ALS. Okay, now, it has a number of other names as well, okay, so I want to talk about these other names so that if you see them you don't get confused. Okay, so firstly, I'm going to tell you about the neurologist who first described amyotrophic lateral sclerosis, and in fact was the person who pioneered the name amyotrophic lateral sclerosis. Okay, so there's a very famous neurologist who is often given the title of the founder of modern neurology. So he is to neurology what Isaac Newton is to physics. Okay, and he is Jean-Martin Charcot. Okay, and you have to say this in a French accent. Jean-Martin Charcot. Okay, right. I think that's how you pronounce his name in French. Right, and he was the first person to use this name, amyotrophic lateral sclerosis. Okay, however, because he effectively described this disease first, the disease is also named after him. So you can also hear amyotrophic lateral sclerosis called Charcot disease. Okay, so that's the second name that I'm going to talk about, so I might just number these up. So this is the second name. This is the main name, amyotrophic lateral sclerosis, ALS is the main name. Okay. Now, another name that's used for amyotrophic lateral sclerosis is also to call it Lou Gehrig's disease. Okay, so Lou Gehrig's disease. Now, Lou Gehrig was a baseball player, a famous baseball player who suffered from amyotrophic lateral sclerosis, and that's why this is also called Lou Gehrig's disease. Okay, so that's the third name that we're going to come across. And the final name is a little bit of a dangerous name to use because it can also mean a different thing. Okay, so the final name, which is nevertheless commonly used, is motor neuron disease. Okay, now why do I say motor neuron disease is a dangerous name to use? Well, in fact, it's a very good name because it describes exactly what's going to happen in amyotrophic lateral sclerosis. You're going to get disease of the motor neurons. Okay, the problem is people use motor neuron disease to mean a whole bunch of different diseases, okay, involving motor neurons. Amyotrophic lateral sclerosis is the most common of the motor neuron diseases. It's the most common disease affecting the motor neurons. However, there are rarer diseases of motor neurons, okay, and those are also counted as motor neuron diseases, okay. So although when you hear people talking about motor neuron disease, most usually they mean amyotrophic lateral sclerosis. Strictly speaking, motor neuron disease means a whole group of different diseases, all of which affect the motor neurons. Okay, so that's why it's a slightly risky name to use. The best name to use is probably amyotrophic lateral sclerosis, and just be aware that if you ever hear one of these other names used, it's referring to amyotrophic lateral sclerosis. Okay, right, so there's the terminology over and done with now. Let's talk about the actual symptoms of the disease. How does it progress? And then we'll move on to which neurons are actually going to degenerate in amyotrophic lateral sclerosis. And we'll see how that gives rise to the symptoms that we're studying here. Okay, right, so let's start off then with the early disease. Okay, so generally symptoms start in the 4th or 5th decade of life. Okay, so 4th or 5th decade it's going to begin. Okay, before that it's very rare to see it begin before the 4th decade of life. Okay, the other thing to say is that it's slightly more common in men than women. Okay, and we don't really know why that is. Okay, it's only slightly more common in men than women. Right, okay, so what are then the first symptoms of amyotrophic lateral sclerosis? Okay, well the first symptoms are that you get painless weakness of the hands and of the legs. Okay, so painless, that's a really important point, that you don't feel any pain, but your hands and legs become weak. Okay, so painless weakness of hands and legs. Okay, and often the first way that this presents is that you'll start dropping objects, okay, or maybe falling over. Okay, so dropping objects, but usually dropping objects is the first presentation of this. Okay, the other first early symptom of this is that you have suddenly difficulty in performing fine movements. Okay, so problems making fine movements, especially with the fingers. Okay, problems with fine movements. So let me give you some examples of fine movements. Okay, so movements such as typing counts as a fine movement. Okay, also handling coins. Okay, so when you're going to the supermarket and you need to handle coins, that is a fine movement because the coins are very small. Okay, other examples are working with tools and things like that. Okay, so those are the initial symptoms, that you have problems making fine movements and you're also starting to get weakness of the hands and legs. But this is painless weakness. That's an important point, that you don't have any pain. It's just suddenly your strength starts to diminish. Okay, right. And then as the disease progresses, it gets worse, basically. Okay, so in the later phases of the disease, okay, you lose all the voluntary movement. Okay, so voluntary movement goes, you just can't control your muscles anymore, okay, because you're losing the neurons which innervate the muscles. So you lose the ability to make voluntary movement. So voluntary movement goes down. Okay. In addition, when you lose those motor neurons that are innervating the skeletal muscle fibers, the other effect of that, as we've discussed previously, is that it causes atrophy of those skeletal muscle fibers, and that neurogenic atrophy is called amyotrophy. Okay, right. Now, two important things also to add on to here and to specifically put is that because you're starting to lose control over your muscles, because you're losing the motor neurons which innervate them, you start getting dysphagia, okay, which means problems with swallowing. Okay, so dys means problems, phagia refers to swallowing, okay, swallowing problems. Okay, and also, and notably, you get problems with talking, problems with phonation. Okay, you lose the ability to speak. Okay, and that's known as dysarthria. Okay, which means difficulty in speaking. Okay, so speaking problems. Okay, so those are two notable symptoms that result because of the inability now to control your skeletal muscles. Okay, right. Now, 3 to 4 years then after the onset of the disease, generally it results in death. Okay, so it usually is fatal. Stephen Hawking is obviously a very famous example of a person who has beaten the odds and lived for much longer than most people would manage to live with this disease. Okay, but generally it kills you 3 to 4 years after onset of symptoms. So okay, so 3 to 4 years after onset, it's going to lead to death. Now, how does it lead to death? Basically, you're losing the ability to control skeletal muscles, okay? So the diaphragm is a skeletal muscle, you're going to start losing the motor neurons which innervate the diaphragm. So your diaphragm's going to become weaker and weaker, and that's going to lead to problems with breathing. And when your diaphragm is just too weak now to actually move enough air into your lungs for you to deliver enough air, enough oxygen to your blood and then to your peripheral tissues, then you're going to start getting problems. And death due to failure of the respiratory system is called respiratory failure. Okay, so to 3 to 4 years after onset, it generally causes death. Okay, and this is because of weakness in the respiratory muscles, because of the degeneration of the motor neurons which innervate them. Okay, and this is going to cause respiratory failure. So you're not going to get enough oxygen into your blood to deliver enough oxygen to your peripheral tissues to meet their needs. Okay, and that's therefore going to kill you. Okay, so that's generally how it leads to death by respiratory failure. Okay, right. So that's the general progression then of this disease. Okay, what we're now going to talk about is which neurons are actually going to degenerate. Okay, and I'll remind you of the motivation for why we're going to talk about which neurons degenerate rather than the process of degeneration first. Okay, it's because the characterizing feature that links all cases of amyotrophic lateral sclerosis is not the neurodegenerative process. That's different between different cases. Okay, the underlying feature that links them all together is which neurons degenerate, and how those neurons degenerating specifically then causes this loss of control over your skeletal muscle cells, which then leads to them atrophying away. Okay, right. So, which neurons are then going to degenerate? Well, it's going to be the neurons of the corticospinal and the corticobulbar tracts, as well as the motor neurons that they're going to actually innervate. Okay, so what I want to discuss now is the anatomy of the corticospinal and the corticobulbar tracts. So I'm going to go over onto the other side and then we'll discuss this. So, we need to know a lot about the anatomy of the corticospinal and the corticobulbar tracts in order to understand which neurons are actually going to degenerate, because it is not just the actual motor neurons which innervate the skeletal muscle cells which are going to degenerate, it's also the neurons of the corticospinal and corticobulbar tracts. Okay, right. So, initially, both of these tracts start off the same. Okay, we will have to diverge at some point. We'll firstly talk about the corticospinal tract and then we'll come back to the corticobulbar tract. And I should probably just tell you what these tracts actually are. Okay, so basically there are motor neurons which innervate your skeletal muscle cells. Okay, and these have their cell bodies either in the spinal cord, okay, or they have their cell bodies in, what does bulba mean? Bulba is another word, the bulb is another word for a portion of the brainstem known as the pons, okay? So, what does this refer to? Well, some motor neurons are going to have their cell bodies in the brainstem, not necessarily specifically in the pons, but in the brainstem at least, so nearby the pons. Okay, as we'll see, a lot of them are going to be in the pons. Now, these motor neurons are going to be part of certain cranial nerve nuclei. Okay, so certain of the nerves that innervate muscles of the facial and neck region, okay, are going to have their origins in the brainstem rather than in the spinal cord. Okay, right, so these neurons, okay, which are the motor neurons which actually innervate the skeletal muscle cells, okay, which have their cell bodies in either the spinal cord or the brainstem. Okay, these are going to be controlled by cortical neurons, neurons that are coming down from the primary motor cortex. Okay, and the corticospinal tracts and the corticobulbar tract, these refer to this projection from the cortex to these neurons in the spine and the brainstem, okay, and that's the means by which you control the activity of these motor neurons. Okay, right, and it's not just the motor neurons themselves that are going to degenerate, it's also the neurons that control them, i.e. the neurons of the corticospinal and the corticobulbar tracts that are going to degenerate in amyotrophic lateral sclerosis. So to understand this, we need to have a good understanding of the corticospinal and corticobulbar tracts. Okay, so, as I say, originally these two tracks start off exactly the same, so we can start off discussing them alongside one another. We'll have to diverge at some point as they split off. We'll start with the corticospinal tract, okay, which will deliver these fibres right down into the spinal cord, and then we'll go back to the corticobulbar tract, okay. Right, and then we'll talk about the motor neurons themselves, and then we'll put it all together and see how these two sets of neurons degenerating is going to give the symptoms of amyotrophic lateral sclerosis. Okay, so before we actually discuss the corticospinal and corticobulbar tract, we need to start off with a little bit of knowledge about the motor system itself, so the motor portions of the cerebral cortex. Okay, so I'm going to start off by drawing a picture of the left cerebral hemisphere seen from the left-hand side. Okay, so this is the cerebral hemisphere on the left-hand side, seen also from the left-hand side. Okay, so here we've got the temporal lobe, right back here we've got the occipital lobe, the parietal lobe, and then the frontal lobe here. Okay, right, now I'm going to put on a landmark structure of the cerebral cortex, which is a sulcus, which means a little invagination of the cerebral cortex that runs all the way down here. Okay, and this is known as the central sulcus. Okay, and it's a usually distinguishable landmark on the side of the brain. Okay, right. Now, why have I put the central sulcus on there? Well, the central sulcus is often used to locate certain portions of the cerebral cortex. Okay, particularly the portion that is right in front of the central sulcus, which I'm now going to colour in red. Okay, so this portion that's sitting right in front of the central sulcus, this is going to be important in the motor system, and it's going to be extremely important in the pathology of amyotrophic lateral sclerosis. Okay, so this portion of cerebral cortex here is known as the primary motor cortex. Okay, and for short, the primary motor cortex is often abbreviated down to M1. M for motor, 1 for primary. Okay, so this is the portion that sits right in front of the central sulcus. Okay, right. Then, in front of the primary motor cortex, we have another portion that's very important in the motor system. Okay, and this is going to be the secondary motor cortex, but it's made up of two separate bits, which I'm going to highlight in different colours. The green portion and the blue portion are both part of the secondary motor cortex. Okay, the green portion then, what's this? This is what's known as the supplementary motor area. Okay, and for short, the supplementary motor area is usually abbreviated down to the SMA for short. S for supplementary, M for motor, and then A for area. Okay, the blue portion then, below the supplementary motor area, is then called the premotor cortex. Okay, and together, the supplementary motor area in green plus the premotor cortex in blue is then known as the secondary motor cortex. Now, the final portion that I want to add on to this before I then talk about how the motor system works is a portion that sits in front of the secondary motor cortex, and I'll put this portion in turquoise. So in front of the secondary motor cortex, here in turquoise, this is what's known as the dorsolateral prefrontal cortex. Okay, so this area is known as the dorsolateral prefrontal cortex. Okay, and for short, the dorsolateral prefrontal cortex is usually abbreviated down to the DL for dorsolateral, so DL for dorsolateral, and then you put a dash, and then PFC for prefrontal cortex. Okay, right, so that's the portion in turquoise there. Okay, now, let me just talk about the reason that this is actually called dorsolateral prefrontal cortex. Okay, because you might be thinking dorso. How is that dorsal at all? That's right at the front of the brain, okay? But you need to remember that whilst ventral and dorsal in gross anatomy mean the same thing as anterior and posterior, so ventral means at the front of the body, anterior, and dorsal means at the back of the body, posterior, okay? When you're talking about the brain, it's quite different. Instead, dorsal means towards the top of the brain here, okay, and ventral means towards the bottom of the brain here. Okay, and you can see that this is quite near the top of the brain, and hence why it's called dorso. And then also it's quite lateral, so it's the dorsolateral prefrontal cortex, and it's called the prefrontal cortex because it's very close to the front here. Okay, right. So those are the different portions then of the motor cortex. So now what I want to discuss is how these different portions work in the motor system, okay, because understanding this is going to be important for us to then understand the corticospinal and corticobulbar tracts and where they fit into the motor system. Okay, right, so this is a very, very basic, crude model, but it's a useful model, okay? So this model says that dorsolateral prefrontal cortex starts off, okay? The function of the dorsolateral prefrontal cortex is often described as executive control. Now, what does this mean? This means it is in charge of actually making decisions, okay? So when you get up out of bed each morning and then decide what you're going to do today, it's the dorsolateral prefrontal cortex that is making that decision. That's the portion that you are using when you make decisions. Okay, so it's the executive controller, basically. So, when you decide that you want to make a voluntary movement, such as, let's say, picking up this pen, okay, the first thing that happens is the dorsolateral prefrontal cortex decides that it wants to pick up the pen, it wants to make the voluntary movement. So the idea occurs in the dorsolateral prefrontal cortex. Okay, the dorsolateral prefrontal cortex is then going to send the instruction to the secondary motor cortex, which, remember, consists of the supplementary motor area, here in green, and the premotor cortex, here in blue. Okay, and what does the secondary motor cortex do? Well, the secondary motor cortex comes up with what is known as a motor plan. Now, this is a really, really important concept, okay, but it's quite a difficult concept to understand. So what is a motor plan? Okay, well, let me try and give you the motivation for what a motor plan actually is. So, in order to actually make a movement, like picking up this pen, you need a huge number of different muscles to contract in order to actually do this, okay? You need many different muscles to contract, and they also have to all contract at the right time, okay? So, the muscles need to be contracting to exactly the right amount, and they need to be contracting at the right time. Now, what actually makes them contract? Well, they contract because they're getting signals to contract from the motor neurons, okay? And the motor neurons relay signals via action potentials. So you're getting action potentials firing along the motor neurons, okay? And many different skeletal muscle fibers have to be activated, and these are going to be innervated by different motor neurons. So you're getting loads of action potentials coming down loads of different motor neurons, okay? So this incredible combination of action potentials that you need coming down loads of different neurons, and each neuron needs to be getting the exact right frequency of action potentials at the exact right time, okay? That incredible combination of action potentials firing down loads of different neurons, that is what is meant by a motor plan. The combination of action potentials that you need in order to actually make a movement, okay? So, which portion of the brain actually comes up with that incredible combination of action potentials? Which part of the brain generates it? That is believed to be the job of the secondary motor cortex. Okay, it comes up with the motor plans, these incredible combinations of action potentials. Okay, right. Then, once it has come up with a motor plan, it sends it on to the primary motor cortex, here in red. Now, for our purposes, the primary motor cortex is just going to be viewed as a relay hub. Okay, all its job is to do is to relay this motor plan now down to the motor neurons. Okay, so basically, for each motor neuron that's down in the spinal cord or in some cranial nerve nucleus, you're also going to have a neuron up here in the primary motor cortex which joins onto that one. Okay, so effectively this is just a relay hub. You're going to activate the neurons in here, which will then send the message down to the motor neurons that are in the spinal cord or the brainstem. Okay, and that's then going to cause the movement to be made. Okay, so for our purposes, the primary motor cortex is just a relay hub. Okay, it's a little bit untrue. It does more than just being a relay hub, but it's certainly a useful model to just think of it as a relay hub. Okay, right. So now what we're going to do then is talk about the primary motor cortex in more detail. We're going to talk about the neurons that are in the primary motor cortex. Okay, so we'll start off then with the neurons in the primary motor cortex, and then I want to explain something known as the motor homunculus to you. Okay, so the neurons that are in the primary motor cortex, there is a special type of neuron in the primary motor cortex, which is the neuron that we are going to be interested in. There are loads of different neurons in there as well, okay, but the ones we are going to be interested in, the ones that are going to send axons down to synapse onto motor neurons, are known as Bett cells, okay? And they're also called giant pyramidal cells, okay, which describes nicely what they are. They are pyramidal cells which are absolutely enormous, and these cells truly are enormous. Okay, they are almost getting to the point where they are visible with the bare eye. They aren't quite visible with the bare eye, okay, but let me explain how big they are. Some of them get to the point where they are 0.1 millimeters in diameter. Their cell bodies are 0.1 millimeters in diameter. Now, a millimeter is visible with the bare eye. That is about a millimeter. Okay, it's a tenth of a centimeter. Okay, so it's that a millimeter is visible with the bare eye. This is a tenth of a millimeter, so that's pushing it at being visible by the bare eye. That would be like a dot like that. Okay, so these are big cells is the message. They're almost getting to the point where they are visible with the bare eye. Okay, right. Now let me show you something about their structure. Okay, so they are pyramidal cells, which means that the cell body is going to be in the shape of a pyramid. So I'll draw this here. Okay, so here is that pyramid-shaped cell body here, which will be in the primary motor cortex. Now, they're also going to have dendrites coming off their cell body. Okay, here's one dendrite, and then there'll be a dendrite coming off the top here, the top of the pyramid, and that's got a special name. That's known as the apical dendrite of the pyramidal cell. Okay, because it comes off the apex of the pyramid. Okay, so this is the apical dendrite, but you've also got dendrites coming off the base of the pyramid as well. Okay, down here. So here's another dendrite. And then right off the bottom of the pyramid, you'll then have the axon coming. Okay, which is the axon that's going to go all the way down through either the corticospinal or the corticobulbar tract to innervate a motor neuron that will be either in the spinal cord or in a cranial nerve nucleus. Okay, so this is what a Bett cell looks like, and it's this cell body here that can almost get to the point where it's a tenth of a millimeter in diameter. Okay, right. So these are the special types of cells that you've got in the primary motor cortex. They're not the only types of cell that you've got in the primary motor cortex, but these are the important ones. These are the ones that are actually going to send their axons down and synapse onto motor neurons in the spinal cord or in the brainstem nuclei. Okay, right. Now what I want to talk about is the motor homunculus. Now this is a really important concept. Okay, this is the concept that different portions of the primary motor cortex are going to have Bett cells which are going to go down and innervate motor neurons that are going to supply different portions of the body. Okay, so motor homunculus, this is called. Okay, so let me show you the motor homunculus, because really the best way to communicate what the motor homunculus is to actually show you the motor homunculus. Okay, so what we're going to do is we're going to draw the primary motor cortex from a different aspect now. What we're going to imagine doing is taking a coronal section of the cerebral cortex here, specifically the left hemisphere cerebral cortex. Okay, so a coronal section means that I'm going to put the front of my carving knife on one side of the brain, okay, that's on the right side of the brain, and the back of my carving knife on the left side of the brain, and I'm going to cut down the middle like so, okay, and therefore I'm going to split the brain into two halves, and then I'm going to look at the opened up aspect, okay, so I can now look at what's on the inside basically. I'm going to take the back portion here, this portion here, and look at that, okay? And I'm going to look at the left-hand side. Okay, so this is what we'll now have. So, basically, here is the left hemisphere here, like so, folded round. Okay, and this is the cerebral cortex, all like so. Now remember, between the left hemisphere and the right hemisphere, you have a large fissure that splits the two hemispheres apart, and this fissure is known as the lateral fissure. Okay, now the cerebral cortex extends into the lateral fissure, and therefore part of the primary motor cortex is going to be facing into the lateral fissure. Okay, so let me explain this in more detail. So basically, if you look at the brain from above, okay, what you'll see is something like this. Okay, here is the left hemisphere here. Okay, and here then is the right hemisphere on the other side. And there is this gap in between the two hemispheres, and this gap is known, sorry, it's not known as the lateral fissure, get rid of this. Okay, it's known as the longitudinal fissure. The lateral fissures down here will come to the lateral fissure. Okay, it's known as the great longitudinal fissure. Okay, I apologize for that. Longitudinal fissure. Okay, and this is the portion that splits apart the left hemisphere and then the right hemisphere here. Okay, now, in this gap you still have cerebral cortex facing into the gap, and part of the primary motor cortex, okay, which remember will be coming up like here, part of the primary motor cortex will face into that longitudinal fissure, okay, so it will be facing in. So the primary motor cortex continues on upwards and then will go down the side there, and you'll have a portion that faces into the longitudinal fissure. Okay, and this is the portion that we're seeing here. We're seeing that portion that faces into the longitudinal fissure. Okay, then as the cerebral cortex comes right round, now we're going right down here. Okay, you'll eventually get to this fissure here that separates the parietal and frontal lobes from the temporal lobe here. Okay, and that's known as the lateral fissure, and again this is an invagination of the cerebral cortex. Okay, so that will come in here kind of place. Okay, right, so this is the entire primary motor cortex then here. All of this is the primary motor cortex. Now we couldn't see all of this on that original picture because some portions of the primary motor cortex face into the longitudinal fissure and some portions face into the lateral fissure down here. Okay, so this is the beginnings of the lateral fissure here, the portion that's facing into the lateral fissure. Okay, right, so I now want to explain the motor homunculus. Now the motor homunculus then is the concept that different portions of the motor cortex are going to have these giant pyramidal cells or BET cells in that are going to be going down and innervating motor neurons, and different portions are going to send their axons to motor neurons that are going to supply muscles in different regions of the body. Okay, so let me explain this then. So the portions nearer the top up here are going to send their axons right down into the spinal cord, right down to the bottom of the spinal cord, and they're going to be innervating motor neurons, which are then going to be controlling the movement of the muscles in the toes, okay, and the ankles and the knee and those sorts of regions. Okay, so the portion right down here that's facing right into the longitudinal fissure, this is a portion that's going to be in charge of controlling the movement of the toes. Okay, so it's going to have giant pyramidal cells in it which are going to go right down, innervate motor neurons in charge of muscles which move the toes. Okay, then a little bit up from that you're going to have the muscles which move the ankle. okay? Then the muscles which move the knee joint, okay, here, and then it's going to continue right on, so I'll go right through this, okay? So next up is going to be the hip here, okay, and this is where it's going to get really messy. How am I going to do this? I'm going to try and think of a good way. It is just going to get messy, I'm afraid. I can't really come up with a way around this. I should have coded it, but it's too late for that now because I've put the red colour on. Okay, so that next portion there is going to contain BET cells which are going to go down and innervate motor neurons which will move the muscles of the hip. Okay, next along from that you're going to have the trunk. Okay, so this portion here is the trunk. Then here, this is going to be the muscles of the shoulder joint. Okay, and we're gradually going up, you see. So there isn't that much space that's devoted to all the joints of the leg, then the hip, and then the trunk. Now we're already up at the shoulder here. Okay, and then we're going to gradually go up further. So now we're going to go along the arm. Okay, so this portion is devoted to the elbow. Okay, so the muscles that move the elbow joint. Okay, then we're going along further. The muscles that move the wrist is here. Okay, so that's that portion there. Okay, then you have a large section which controls the movement of the muscles of the hand. Okay, so note, humans have very incredible hands. We have incredibly fine movements. We're capable of incredibly fine movements of the hands. Okay, this means we're going to need more primary motor cortex dedicated to the movements in the hands than we are for primary motor cortex dedicated to movement in the feet, where we're capable of much less dexterous movements. Okay, then after the hand you have little portions for each one of the fingers. Okay, here. So this portion here is for the little finger. Okay, and then it works its way along. This second portion is for the ring finger. Okay, third portion here is for the middle finger. Okay, the portion after that is for the index finger. And then the final portion is for the thumb. Okay, so you have little portions of the primary motor cortex which contain BET cells which are going to go down and innervate motor neurons which will control the movement of each one of the digits, basically, specifically. Okay, right, then after we've done all of the digits then, next up what you'll have is the portions which control the movement of the muscles of the neck. Okay, so this portion is going to be the neck muscles, then the brow muscles here. Okay, then going up further we're going to have then the eyelid and the eyeball. Okay, so this bit's going to be responsible for moving the eyelid and also the muscles which move the actual eyeballs, the ocular muscles. Okay, moving on from that you're going to have the muscles which innervate the face, the muscles which move the face. Okay, so the muscles of facial expression. Okay, then the lips. Okay, and the lips you have quite a large section for. Okay, then you'll have the jaw, then the tongue, and then the swallowing. And unfortunately it's got a little bit out of hand because these ones shouldn't be as big. I've got too much space is the problem. So forget that this bale portion here exists. Usually I end up with far too little space, okay, but here I've ended up with far too much space. Okay, so you'll have the jaw here, the tongue here, okay, and then BET cells which are in charge of innervating motor neurons in charge of swallowing here. Okay, right, so this is the motor homunculus. Now, you do not need to know this. What I have put this here to do is illustrate the concept that you have different portions of the primary motor cortex which are going to be sending axons down to control motor neurons that are going to be innervating skeletal muscles which are in charge of moving joints at different portions of the body. Okay, and I think the best way to illustrate that is just to show the motor homunculus. Okay, right, so this then is the primary motor cortex. It contains these giant pyramidal cells. Okay, now the giant pyramidal cells in each portion of the primary motor cortex, they are all going to be sending their axons down into the subcortical white matter. So the axons are all going to be coming down into the white matter, basically, away from the cerebral cortex. Now remember, the cerebral cortex is the place where all the cell bodies of neurons of the brain are kept. Okay, then there's this huge, great lump of white matter which consists of the axons of the cerebral cortex neurons. Okay, so you're going to be sending all of the axons into the subcortical white matter. Okay, and from the subcortical white matter they are going to go into a structure known as the internal capsule. So now we are beginning the corticospinal and corticobulbar tracts. Okay, now at the moment the two pathways are exactly the same. You're getting axons coming down from the primary motor cortex. Many of these axons over here are going to end up going into the corticobulbar tract, and these ones are going to end up going into the corticospinal tract, because these ones need to go down to the peripheral body and therefore need to go into the spine. These ones are going to go to the head and neck region, okay, and therefore they don't need to go right the way down into the spine. Okay, but for now the pathways are identical. The neurons of this portion and the neurons of this portion, their axons are all going to follow the same path. So they're firstly going into the subcortical white matter, and now they're going to go into a structure known as the internal capsule. Okay, now to show where the internal capsule is, we need to know quite a bit more neuroanatomy. Okay, and it's that neuroanatomy that we're going to turn our attention to in the next video.